I think we'll get started, and by the time we get to the real juice of it, the presentations and all the good stuff, hopefully we'll have more participants joining. And thank you all for being here tonight. Good evening, everyone. My name is Brittany Groom, and I'm a health policy analyst at the Registered Nurses Association of Ontario. And it is my pleasure to welcome you to our webinar tonight, focusing on the topic of recruiting, retaining, and advancing Black nurses. This webinar, hard to believe, but is our 10th installment in the Let's Talk About Anti-Black Racism and Discrimination in Nursing series. Now, please allow me to introduce Dr. Angela Cooper-Brathwaite, immediate past president of RNAO, and my fellow co-chair of the Black Nurses Task Force. Well, usually I would be Corsita, and unfortunately she couldn't be here this evening. Angela will go over a few Zoom housekeeping details before we get started with tonight's webinar. And we also have Irma-Jean Baynock here, RNAO's Senior Policy Analyst, and she will help to answer any questions you may have and keep the webinar running smoothly, including these IT issues that we're facing this evening, but we'll work through. So Angela, take it away.
Thank you, Brittany, and I just want to welcome our guest speakers, our colleagues, our friends, our CEO, all our assistants. Thank you for joining us this evening. And I'd just like to go through a few of our housekeeping tasks to help you during this process. So whether you've participated in RNAO webinars before or you're attending for the first time, I would like to let you know that you could participate by typing questions in the Q&A box or the chat box throughout the webinar, or you could raise your hand, use that icon to raise your hand, and that will come in very handy when we have question and answers from the panelists. We do have an engagement in a poll, so I have two optional questions and you could choose to answer them. And once you answer them, by the time we tabulate, we would see what percentage of people were able to answer those questions for us. The webinar is being recorded and will be posted on RNAO event page. Tonight, the webinar is scheduled to run from 6:30 p.m. Sorry for our late start, until 8 p.m. We might go a bit later. And Dr. Doris Greenspan, our highly esteemed CEO of RNAO, will deliver the opening remarks. We will briefly check the pulse on RNAO's Black Nurses Task Force and then dive right into two of the webinars, focusing on our topic tonight, recruiting, retaining, and advancing Black nurses. We are proud to host three amazing speakers who will be presenting and engaging in our panel discussion tonight. Suzanne Charles, Ingrid Taylor, and Dr. Josephine Etowa. There will be an opportunity or opportunities for question and answers when we do that in that period. And we will close the webinar with a few call to action and updates from RNAO. Please join me in welcoming Dr. Doris Greenspan, our CEO, so she could bring some remarks tonight. Doris.
Thank you so very much, Dr. Cooper-Brathwaite. And what a day and what a year and what a period this is. In the midst of so many issues that are important to every Ontarian, including, of course, the challenges of COVID-19 and the latest third wave that many are deeming it as the racist wave. So this is very apropos our webinar today, given what happened today with the call to the Premier to resign. RNAO was called for a reaction, and our reaction was that Minister of Health and Deputy Premier Christine Elliott should take over the pandemic simply because she will manage it perhaps in a different way. So follow those news because it was very interesting that the Premier was not at question period, and Minister Elliott did share quite openly that there had been lots of discussions about how to tackle the third wave. And as she put it, let me leave it at that. kind of indicating that not everybody was on the same page. It is very serious. It's very serious because the people that are paying the price are people of very vulnerable communities, and therefore it's very apropos everything we are speaking today. It also is very apropos the fact that it's really tearing apart not only the soul of communities and families, also of our own colleagues, nurses and physicians, which likely will see themselves doing triage this Friday. So that's one piece that is important. Another piece that is important, which some of you, I hope, have heard, is the process that is happening at York University with Professor Alonso, which I sent to the task force the information. Again, a situation that I am not fully informed, but that is being perceived as issues of discrimination. What RNAO says about any aspect that is related to that is that there needs to be a fair process, independent process, so things can be looked and addressed properly. So those are issues that keep an eye on, keep informed on, and some of you are not foreign to those issues. You live it every day in your workplace, in your life, so keep us informed. With that, I would like to say one call of action, just in case that people start to dwindle away towards the end, which is sign, please, the petition that RNAO has on the website. And imagine if you can put a link or an Marie related to the need to close all non-essential warehouses to protect the vulnerable workers that are in those warehouses. We are not talking about the warehouses that they, develop drugs and produce drugs and food processing. We are talking about warehouses like Amazon's and others that, we can all do away without the nice shoes or the nice shirt or the night whatever, and protect the workers instead until they really receive vaccination, so that we lose less people. So please take action. Government is listening probably even more than before, given all the situation that is evolving. And the situation evolved out of a newspaper actually in the US, not the way we would like to be perceived in the US, but actually was the Washington Post that called first the resignation of our premier. Not the way we would like to be seen south of the border, not the way we would like to be seen here. But all we can do as nurses is keep calm, keep focused on delivering the care that our patients desperately need and will need even more so. Keep reaching out to one another, because those that are in the front lines are having a very, very, very tough time. So please keep an eye for one another, support one another, and together, as we say at RNAO, together we can make it happen for the sake of Ontarians and for the sake of some level of stability. And I do hope that Mr. Elliott listens to us and, it takes a much more control over the situation. So with that, I return it to you, Madam Vice President, for introduction of our amazing panelists that I'm so thrilled to see.
Brittany would now bring the objectives of the webinar for this evening, and I will follow Brittany.
Thanks, Angela, and thank you, Doris. And we will absolutely revisit that action alert closer to the end and see if we can capture more people then. In the meantime, I'd like to talk to you about the Black Nurses Task Force. So in 2020, for those of you who aren't aware, RNAO launched the Black Nurses Task Force to tackle anti-Black racism within the nursing profession. We're talking about the nursing organizations, the healthcare organizations, the regulatory body, associations, and the broader health system. And we really wanted to address that targeted towards and experienced by Black nurses. So this task force is made up of 17 Black identified RNAO members. As you can see on your screen, Corsita Garraway and Angela Cooper Brathwaite are the fearless co-chairs and leaders. And this group is made up of RNs, NPs, and nursing students, many of whom are here tonight watching and listening. And there's representation in this group from diverse nursing career stages, roles, health sectors, geographic locations, institutions, and completely different lived experiences. So our next meeting is scheduled for May 26, 2021. We meet bi-monthly. And this webinar series is just one activity of the task force by which we really aim to elevate the voices of Black nurses and Black professionals, celebrate the contributions to nursing and healthcare, create a really safe space to engage in meaningful dialogue around anti-Black racism and discrimination, and raise awareness amongst the broader nursing and healthcare community about some of the core issues that need to be addressed. So we're going to culminate in a final report with some key recommendations that we're working diligently on right now. And in addition, I have an ask of all of you who are here today. We're working on establishing a repository of resources specifically to anti-Black racism and discrimination within the nursing profession. So I do encourage any and all of you to send me to my email, which I'll share, resources that you have found particularly useful and helpful, and we will share that soon. With that being said, the objectives for tonight include, but are not limited to, generating awareness on the underrepresentation of Black nurses in leadership and executive roles in healthcare, describing strategies to incorporate equity, diversity, and inclusion in hiring processes, exploring some of the best practices and the effective strategies for recruitment, retention, and advancement of Black nurses, and identifying the meaning of sponsorship and its differentiation between mentorship and really its value in the progression of Black nurses.
Okay,
I'll hand it
it's
back
my
to Angela.
turn. So I would like to ask two questions this evening, and as I mentioned earlier on, everyone could participate, but it's not mandatory. So the question is, in your healthcare organization or academic institution, what percentage of executive leadership positions are filled by Black professionals? So it rates from below 25% to above 75%. Please submit your answers. Okay, we'll wait for the results. Okay, 90% said it was less than 25%. And then another group said 10%, between 25 and 50%. So we see how few Black people are in leadership roles, whether it's in academia or in the workplace in different health settings. My next question is, in your healthcare organization, next question. Does your healthcare organization or academic institution have a diversity, equity, and inclusion committee? The answer is either yes or no, please, or I don't know. Please submit your responses. Okay, yes, 58% said yes, 29% said no, and 14% said I don't know. Thank you so much for your responses. And now that we've set the pace for this presentation, I'll now turn over to Brittany, who would introduce our first speaker.
Great. So I have the pleasure of introducing tonight Ingrid Wilson to speak. Ingrid Wilson is an accomplished senior executive with almost 30 years of experience in corporate human resources, board, and business strategy. She has organizational experience with not-for-profit, public sector, private and public companies in regulatory environments with global expertise working for organizations with diverse operations, including in the US and Europe. She has expertise in diversity, equity, and inclusion, and systemic racism, developing and executing on organizational strategies to foster an inclusive work environment and communities. Ingrid also currently volunteers as a mentor with Black Mentorship, Inc. and Sheridan College. Ingrid also serves on the HR Advisory Group, Rotman School of Management, and on the HRPA, Nominating and Appeal Board Committees. Ingrid, please take the stage.
Thank you, Brittany. So I'm so honored to be invited here today to speak. Lots of respect for all the doctors and nurses on the front line out there. It's been a challenging year for us and even more for all of you on the front line. So today I'm going to speak about recruiting, retaining, and advancing Black nurses. And I have to tell you, doing the research on this topic, I was quite surprised to see some of the systemic racism issues that are quite prevalent still. So Brittany, can I ask you to advance the screen, please? Okay, so to understand the underrepresentation of Black nurses in leadership and executive roles in healthcare, and I saw somebody ask in the Q&A, what level is that? And quite frankly, we're not just talking about the C-suite, we're talking about leadership management roles in general and up. So we need to first start with education and build an understanding of systemic racism within nurses. So it starts before the recruiting process, quite frankly. And it stands that the impact of systemic racism continues to be omitted and diminished within nursing education. So efforts to recruit and retain underrepresented groups, students and faculty, is an issue due to the lack of accessibility, so financial and societal. So there's a lack of understanding that, quite frankly, not everybody can afford to go to nursing school, whether it's because of the cost going to nursing school or the impact in society of having to take care of children, help within families, working several jobs. It is a challenge. There's also systemic processes that are created in nursing schools. So a lot of time access to medical and nursing school is restricted. So for nurses in particular, although the schools opened in Canada in 1874, Black students were not allowed to attend until the 1940s. And that was after pressure from community groups and organizations. On a wider basis, we also see that on impact with medical doctors. Brittany, can you advance the screen? Thank you. So we're exploring best practice and effective strategies for recruitment, retention, and investment of Black nurses. So we hear this phrase, tokenism, hiring or promoting one Black person. So the challenge nowadays is that everybody's calling for raising the levels and making sure you hire Black and diverse individuals into each of these areas, including nursing. The problem is that a lot of organizations hire one Black person and feel that they've checked the quota and they've moved on. So tokenism is not. Also, putting a pool of Black nurses together and saying we've gathered a pool of nurses that we've interviewed, but then putting them aside and not moving them up within the organization or hiring them is not actually advancing Black nurses. So to address this, specific goals need to be set for diversifying the pool and working with schools and community organizations to create that pool. So in terms of succession planning, there's very few up and coming leaders coming up behind us. So we need to start working with the schools to make sure there's programs to get more Black individuals into nursing schools and start developing that succession plan. And interrupting the biases. So, you know, when roles come up within the organization, it shouldn't be just who you know, it should also be the best person for the role. So can you guys all hear me? Am I frozen?
No, we hear you.
Okay, perfect, thank you. So yeah, so ensure all resumes and all experience is reviewed based on the same objective criteria. So it doesn't have to be, for example, that the criteria is so high that it eliminates certain groups or races, and making sure that you use inclusive language through the recruiting process. And diverse panels has to be used. If the organization leadership doesn't have diversity in the diverse panel, work with communities and community leaders to help build that panel. And it's also important to understand the impact of the language of culture. So some cultures, some groups don't interview the same way. And that's because in our culture, we may not be able to look somebody directly in the eye. You, out of respect, you're gonna look down. If there are men in the panel, you may not speak up. You may just be a yes and a no answer. So always remember body language. There's so many things that are involved in the language of culture. It's not just a difference in language. Brittany, can I ask you to, thank you. So for retention is just as important. Once you recruit these nurses and get them through the door, retention is also important. It can't be just that I'm the only one here. There's nobody in leadership that looks like me. So here are some issues that needs to be addressed to create value. Do Black nurses and nurses from other racialized groups have a voice in diversity and inclusion initiatives? So for some hospitals or medical facilities, if there is a D&I committee, are individuals from this group invited to speak at that committee? Are Black nurses and nurses from other racialized groups represented in union negotiations in terms of wages, total rewards, and is there data on wage disparity due to lack of promotion? Because the challenge is, if this group is not promoted, their compensation is affected because they don't raise through the levels. That means no raises, compensation stays flat. Build succession plan and career development opportunities. So what are those career ladders? Make it very clear that these are the ladders and these are the career paths that nurses can go through. So the nurse practitioners that we see out there who are very effective as well, and provide access and accommodation for continuous learning and development. So providing stretch assignments, making sure that Black nurses are not on the shifts that nobody else wants, for example, so they have opportunities to participate in projects and other options for learning. Inclusion measures are also required to move from current straight along the diversion and inclusion journey. So progression rates, hiring rates, etc. So are you asking a question about diverse panels? So diverse panels, just to be clear, if you don't have that diversity within the hospital, you should reach out to other hospital networks where there are other Black nurses, Black medical doctors and officers, and of other races that can add to the panel and give you a more objective panel when recruiting. Brittany, can you change the slide? So again, tokenism is hiring or promoting one Black person does not solve the problem of discrimination, and it has not been successfully addressed. And a big challenge is the fish in the water analogy. So if you're the fish swimming in water and that's your environment every day, and you don't know anything else, you may not understand the challenges that are being faced by other individuals who are not fish, for example. They're not from the same race. So you may not able to see the problems that's created in the structure. And again, diversity inclusion committees, setup of those committees is not going to solve the problem. All people, all levels within the organization must be involved. Because sometimes there's a tendency for the diversity and inclusion committees to just respond to an issue that's at top of mind, one issue, and not really focus on the systemic issues that have been coming along all the way. So you need to have nurses from the staff level all the way up in the D&I committee. It just can't be a leadership team. Brittany? So here's one of the strategies that we often use to go through diversity inclusion hiring processes to incorporate equity. So the first step is auditing the system to identify blind spots, such as unconscious and implicit bias, archaic processes. You know, you always hear, this is the way we do things. So challenge that. Why is this the way we always do things? And the talent pipeline that could eliminate qualified Black, Indigenous, and racialized candidates. I actually just worked with a group of recruiters previously presenting, and it's really important to make sure that the recruiting company, if you use a recruiting company, also has training in unconscious and implicit bias. And if you are using a specific group, it should be priority to get them trained appropriately. Identify critical roles, skills, and gaps. Work with leaders to identify what combination of talent the organization needs to meet strategic goals. Make sure you're not eliminating individuals from the roles because they haven't gone to a prestigious school, or because with Black nurses, we may not have had that opportunity to go to those schools. So why are you asking for that higher level education? Why are you asking for that elitist school? So again, it's finding the right balance between data-driven targets, which is what we call diversity. So most hospitals have diversity. You have Black nurses, but they're not moving through the succession planning process, right? So how do you move from that diversity into inclusion and make real culture change? So this needs to be embedded into every people strategy, which is your human resources policies, your recruiting policies, your performance measures, everything that touches people to ensure that unconscious and implicit bias is addressed. And for this to succeed, this process must start at the top of the organization and filter all the way through. Brittany, can you change the slide again? So sponsorship is not well understood. You hear a lot about mentorship, but before you can move to sponsorship and mentorship, there needs to be volunteerism. And as a culture within the Black community, this is not something we do well. We tend not to volunteer, and that's because we have different focus. We have to pay the bills, we have to take care of family, and sometimes there's multiple other things going on. So it's important to understand that systemic racism cannot be solved by one person. So if you have an opportunity to volunteer, that is the best thing to do. And if you can volunteer in a mentorship role, that's even better. So it's really important for Black nurses to see that there are other nurses that look like them in the leadership pool. So once you get into that leadership pool, it's really important to turn around and give back. And mentorship can involve formal or informal relationship. So advising or just being the voice on the phone and act as a role model. Sponsorship is the next level. It's a relationship that has to be earned. It has to be on an individual basis rather than assigned. So somebody willingly feels that they are going to move past mentorship and speak up for a person. So if a job comes up, I'm going to say that this person is the right person for the role, and advocating and sponsoring that person and helping them guide them through that journey and their career through the organization. And I think that's the last slide. Brittany. So thank you for your time tonight. Really, really appreciate it.
Thank you so much for your contribution, Ingrid. And we look forward to the next discussion when we have participants ask the panel some questions. I would like to introduce my friend, colleague, Dr. Josephine Etowa. Josephine is a full professor and OHTN chair in Black women's HIV prevention of care in the Faculty of Health Sciences at the University of Ottawa. She is a past loyal, the Silver Research Chair in Public Health Nursing, and the lead investigator of collaborative critical research for equity and transformation in health lab, and is a senior investigator with the Center for Research on Health and Nursing. Dr. Etowa is a founding member and past president of the Health Association of the African Canadians in Nova Scotia and the Canadians of African Descent Health Organization in Ottawa. Her research program includes national and international funded studies on health equity, perinatal health, HIV/AIDS, COVID-19 pandemic, nurses' work life, and community health nursing. She has studied the work life of Black nurses, of viable minority nurses, Indigenous nurses, and nurses of color. Her research is informed by an intersectionality lens and community-based participatory research approach. She's currently leading 3 nationally funded COVID-19 studies. Her current project include advancing health for COVID in Ontario, strengthening providers' capacity for best practice in African, Caribbean, and Black communities, which is a CIHR grant of 2020. And the next one is rapid assessment of the impact of COVID-19 on access to sexually transmitted bloodborne infectious related services in the ABC communities. Please join me in welcoming Dr. Etowa.
Thank you, Angela. My internet is so unstable, so I'll turn off my camera and share my screen.
Okay.
If you don't mind.
We can see.
Okay, great, thank you. So I would go right into it, and thank you for setting the tone so well, Ingrid. I would just build on your presentation and just add the other pieces. So again, these are the objectives of that was shared with me regarding what we needed to address today and this evening. And I thought, how am I going to speak about racism that I've been working on over the last nearly 3 decades in 7 minutes? But I thought I'll start with, when we talk about racism in the healthcare system or even in nursing, a topic that is so dear in my heart, and as I continue to examine racism even now, I continue to see the same things I was talking about 15, 18 years ago, looking at racism in these different social locations, looking at racism among Black nurses, racism among Indigenous nurses, racism among other visible minority nurses, and racism among white nurses in the context of diversity. So Angela, actually, when you say nurses of color, that wasn't an error. It is white nurses. I did study white nurses to tell me about racism, or to tell me about diversity in their workplace and how they handle it. Because quite often when we're talking about diversity, it's very easy for us to move straight to patient population and begin to talk about how diversity affects our interaction with our patients, but it's uncomfortable for us to talk about how we treat our colleagues who look different, who speak with accent. And that's one area that I've also examined closely, looking at 5 major health center or health academic centers in Ottawa. And so in order to talk about retention, we must reflect on those things that is actually pushing away nurses from certain organizations or from the system. And so I thought I'd just talk about the pull factors that arise from outside. So the organization has no control over those, that like somebody offering another high-paying job or the desire to pursue other lifelong dreams. But the real issue comes from the push factors, where nurses have these push factors, Black nurses or nurses from racialized background, that they feel disconnected sometimes from the commitment, or even when an organization commits to creating an environment or to creating the equity, diversity, and inclusion. You may say that in paper, but what does that really look like in practice? I notice many of us click on that poll, yes, that we have equity and diversity policies. And I struggle before clicking on that yes, because I know we have it. But what does that really mean in terms of our everyday practice? And so I think about the limited opportunities that are available for nurses. And they've been talking about this for years. And even now, right now, we do have a national study called The Strange Faces on the Hallway in terms of the health professions, led by my colleague Brenda Bagan. I lead the Ottawa site. And we even in 2021, I'm still seeing the same patterns and the same issues that Black nurses talked about. We're looking at physicians, nurses, social workers in different disciplines in terms of the visible minority groups in those professions. And we're getting same stories now than we did. So not much has changed, even though we've been talking about this, written books about this, working with organizations to develop diversity policies is still looking the same. You look across the country, you can hardly find one dean that is Black in nursing or even in healthcare, or indigenous, and we continue to talk about this. So I'll move to the next slide. I won't read every bullet here because some of these issues actually Ingrid has pointed to them, but I want to actually use the voice of Black nurses themselves to highlight the issues that we're talking about here. And this comes directly from one of my studies. This is a Black nurse saying, we as Black people not only have to be good, we have to be 10 times as good, 10 times better. And you always feel as though you have to prove yourself, that you have to be on top, that you always scrutinize, because the slightest mistake you make, it will be noticed and recorded. Another person said, as a Black nurse, you make a mistake, you're gone. They will find a reason to get rid of you very easily. So you're hesitant to rock the boat because it will make waves. We need to think about what this really means for these nurses. And when we're talking about retention, where we really need to take those issues to, whether it's really taking it to that individual level, but not only individual level, as Ingrid pointed out, working it all the way to the system level, more of a social ecological model of looking at the individual and moving it forward. And so strategies for
internet.
Josephine, you just cut out there. If you want to repeat maybe the last 30 seconds.
She doesn't seem to be hearing us.
No.
I think she dropped out.
we'll wait for her to rejoin. I don't want, oh, there she is. And share her screen. Sorry about this, everyone. Hopefully you can understand the widespread internet issues today, but we'll keep managing. Hi, Josephine.
Oh my goodness.
Meanwhile, I put some important information given what we are discussing in recruitment and retention. So I put some information there for people.
Oh my goodness, start my video. Can you hear me?
Yes.
Good now.
Again?
Yes.
So, Josephine, can you send your
Hello?
slides to Brittany? Because Brittany, if you share her slides, then it will protect her internet a little bit more.
Sure.
So she can speak to the slides.
I'll try and type that to her.
I'm glad that we still surpass 100 people. So they succeeded to connect.
Can you hear me?
Yes.
Yes.
Okay. I'm using my data from cell phone. Hopefully that stays on. Okay. Do I need to share my screen again?
Yes, it disconnected.
Okay. Let's see.
And if that's an issue, then you can send them to me.
Okay. No, I should be able to share screen.
It's much clearer now.
Okay. That's good. Share.
That's great.
Perfect.
Okay. Okay, so I was just talking about some of the strategies for retention. Sorry about that. This internet issue today is unusually difficult. I talked about the need for us to look at interventions that target the causal pathways to these inequities we're talking about when we talk about nurses' lack of representation in leadership role. So effective anti-racism intervention requires systems to unpack the many layers of societal forces that has created these inequities in the first place. So pacifier approach, or using the band-aid approach to try and create different policies at this stage, is not what we need. And so now that we're all talking about racism and we're actually looking at addressing them, we must pay attention to what our organizations are actually doing to make sure that we are not just taking a band-aid approach, that we're actually addressing the issues completely. And again, like Ingrid said, we want to pay attention to our everyday decisions and how it impact on anti-racism, anti-Black racism goals in our organizations. We want to look at who is hired, who is doing the hiring, what activities are taking place in our different organizations, which populations are present at the decision-making table. We need to be able to recognize that. How are the strategies we're talking about implemented and evaluated? Are there evaluation strategies to actually look at what we are implementing? Because everyone is talking about collecting data now. We finally can collect race-based data. Hopefully we're doing the same in nursing to be able to collect race-based data. But how are we using it to be able to implement the needed changes? So increasing awareness and understanding of the experiences of racialized people in nursing is critical to any decisions that we would be making around retention and advancement. Creating an inclusive workforce, again grounded in evidence, developing organizational diversity strategies that are informed by those impacted by these issues. We cannot afford to, once again, ask Black nurses to sit at table where there are tokens. Like you already pointed out, they need to actually be at the leadership table if we truly want to create change, and we want to be able to give them the voice to use evidence to inform the decisions that are made at this decision table. But even at the individual level, we need to examine our own unconscious biases and also that microaggressions that we see every day in our workplaces. On the individual level, we do that because those actions we take at the individual level has impact on even systemic change. Because if you're a leader, the acts of omission in itself is discrimination. The agenda items you choose to bring to the table, actually, that in itself is discrimination. So acts of omission, inaction in the face of need is discrimination in itself. So I would move to this. And I want to highlight the idea that we cannot continue to talk about equity. And I like this image, even though it's been circulating for a long time. I think whenever I picture this image, I think about what we really need. And when I see even this image talking about equality and everyone getting a box to stand on, irrespective of your height, irrespective of what else you have, or some people getting one box and others getting two boxes. I think about even the issue that Ingrid touched on, that why are we looking for certain schools or certain places where maybe some of the minority people cannot reach. What I see in this is, why are we leaving the fence still there? Take down the fence so that everyone can see and will not need to stand on something. So when I see this, I think, when are we going to really act on the thing that is creating the barrier in the first place? The fence is what's stopping the little guy from seeing. Let's take down the fence. So every time you think about an intervention being planned in your organization, think about, is this really touching on the fence? Or once again, they're giving one person information that another person maybe has more of that information and would stand as high as the person who has many boxes here in our everyday reality. And so let's think about that. And I just want to conclude by saying that anti-Black racism in nursing work is deeply rooted in social justice, and intersectionality is a key to addressing it. We must look at the multiple layers, the intersections that occur when you talk about anti-Black racism in nursing. And so organizations that have internal capacity to anchor social justice in their work and work in true partnership with the different communities, racialized communities, in this case, African, Caribbean, and Black nurses in Ontario and beyond. Those are the people that would be able to make the impact we're talking about. And it needs to be done with equity-informed research, and even the policies we engage in has to be informed by equity-informed research. And we want to ensure that programs and services meet the needs of ACB community nurses. And I more and more we're using ACB because we want to make sure that no nurse is left behind. African stands for the nurses migrating from the continent. The Caribbean stands for those nurses of African descent from the Caribbean region, and Black for those nurses of African descent who have lived in Canada or in the Western world for multiple generations. And when we use all three, we ensure that everyone is taken along and no one is left behind. So I'll stop there. Thank you.
Thank you so much, Josephine, for that presentation. It's really an eye-opener. So I'll now pass it on to Brittany to introduce the next speaker.
Absolutely. So next and final speaker of the night before our discussion is Suzanne Charles Watson. Suzanne is an equity, diversity, and inclusion specialist living and working for equity, inclusion, and human rights and social justice. She holds a Bachelor of Science in Sociology, a graduate diploma in International Relations, and a master's degree specializing in gender equity studies and social policy. She is also a certified project manager and was awarded a 2010 Fulbright Scholarship to pursue studies at the University of Michigan's Institute for Social Research. She is currently working on her PhD, which focuses on issues of equity in education systems. She is recognized as an EDI subject matter expert with over 15 years of successfully designing and managing large-scale interdisciplinary research initiatives and developing research-driven, equity, responsive, and inclusive policy. She has worked with a wide range of stakeholders and actors in international development, academia, government, and civil society to design and implement equity, responsive, and strategic policy. Since joining Sick Kids in 2019 as program manager for EDI at the Hospital for Sick Children Research Institute, she has worked to mainstream equity, diversity, and inclusion best practice across the research enterprise. Without further delay, Suzanne, I'll allow you to share your screen now to take it away.
Thank you so much, Brittany. I am hoping that my bandwidth will allow me to continue to have my video on. First of all, I would like to say it is a distinct pleasure to be joining you and the entire RNAO organization this afternoon as we discuss a very, very important issue, one that is dear to my heart. But before we start, I would simply like to take a moment to acknowledge the enduring presence of Indigenous peoples on this land for thousands of years, and to share my appreciation for this opportunity to gather here with you today in service of social justice. I also want to stand in solidarity with communities all over the world today as we advocate for social change and for social justice. So my presentation is going to be a little bit different, and I want us to start thinking. We spoke about looking at data, we spoke about certain lived realities for the nursing community. I want us to go back a bit. We want to get the backstory to why we are seeing the gaps that we're seeing in the nursing profession. So I want us to start from the premise of COVID, and I'm going to explore a bit of how structural and systemic racism has shown up in the profession and what we can do to address those issues. It's no secret that the burden and long-term consequences of the coronavirus pandemic will be profound. The reality is, however, that not everyone will experience the virus nor feel its impacts in the same way. At the best times, structural discrimination worsens inequalities surrounding access to healthcare and provision and treatment. And history provides ample evidence that marginalized communities are disproportionately impacted by health crises. For nurses, this disproportionate impact is felt both in terms of who provides frontline care and to whom care needs to be given. In terms of those requiring care, data from Toronto Public Health on reported COVID-19 cases among ethno-racial groups show that Black persons and persons within the Black community who identify as Black and other people of color make up 83% of reported cases, even though making up only half of the city's population. Also of note is that people of color make up 71% of those hospitalized by COVID-19. On the flip side, data shows that in Canada, Black nurses are overrepresented in entry-level and non-specialty and non-licensed clinical roles, such as continuing care assistants, personal care workers, such as those facing the current pandemic head-on. But they remain disproportionately underrepresented in the specialty areas, advanced practice, and senior management roles, which we heard from our two previous presenters. This exclusion, however, is not new. And as far back as 1910, with the publication of the Flexner Report, which saw the closing of many Black medical schools across North America, Black physicians and nurses have had to navigate various systemic hurdles in accessing training, delivering healthcare, and building successful and sustained careers. We heard about recruitment, but we're also thinking about retention as well as moving up in the hierarchy, which is something that we're still seeing Black nurses facing barriers. Premised on Flexner's own indifference towards women, Blacks, race, gender, region, and class, what happened was a very narrow window of possibility now exists that reverberates in medical institutions and practices even today, where Flexner's own racism would go on to inform institutionalized racism across healthcare provision, and more dangerously, continues to inform and uphold systemic structural racism that Black nurses continue to encounter today. The United Nations defines systemic or structural racism as an infrastructure, an actual deliberate set of interconnected rules, policies, ideologies, which tends to entitle one group in society with certain rights and privileges, while denying other groups in that same society those same rights and privileges. And this is because of long established and long held cultural prejudices, religious prejudices, myths, xenophobia, and so on. Similarly, the Ontario Human Rights Commission considers systemic structural racism to include patterns of behavior, policies, or practices that are part of the structure of an organization, or in fact an entire sector, like the health sector, that disadvantages or fails to reverse the ongoing impact and legacy of historical disadvantage of racialized persons. And while racism is a system that is implemented in every part of the society, it's important for us to understand that racism plays out differently and appears and shows up and is manifest differently for different groups of racialized people. So the term anti-Black racism, which was first expressed by Dr. Kua Benjamin, of a social work professor at Ryerson University, she sought to highlight the unique nature of systemic racism on Black Canadians and the history, as well as the experience, how that history of slavery and being colonized has continued to impact the lived realities in contemporary times for Blacks. And anti-Black racism can be defined as policies and practices rooted in those systems that we spoke about earlier, such as education, healthcare, the justice system, which tend to mirror and reinforce beliefs and attitudes underpinning discrimination against Black people and people of African descent. And it's interesting because more recently, we're starting to hear the terms BAME, Black, Asian, Minority, Ethnic, or BIPOC, Black, Indigenous people of color. But we have to be careful because what these terms tend to do is they tend to mask the specific lived realities and experiences of being Black. And that can potentially block any efforts to dismantle in a real and transformative way structural racism that is directed specifically at Black people. So we need to be careful about how we bandy about those terms. The distinction among racialized groups is important, particularly when one considers that anti-Black sentiment has actually been embedded within the very curriculum that is used to train nurses. So not only do we have a history of exclusion, the tools that we use in the profession are inherently racist. And a scholar, Keisha Jeffries, notes that nursing curriculum continues to be riddled with colonial, anti-Black, heteronormative, and hegemonic content. And she laments that for most of nursing's history, aspiring nurses have been taught to care for white, straight, and gender binary patients. And if this is not you, even a routine hair, skin, or health history assessment can pose a challenge. And unfortunately, this continues to be so. In a June 12, 2020 tweet, the Canadian Nurses Association cited anti-Black racism as a public health emergency in Canada, and it noted its negative impacts on the nursing profession, as well as, very insightfully, its own contribution to that development and sustaining of structural racist practices, calling out its own contribution to centuries-old injustice. And this has had an impact on the health and well-being of patients, from the care being provided to the inequitable outcomes we see in healthcare disparities. And there's a growing body of evidence to support the need for open and honest discussions about race, racism, and their impact on health disparities. And recently, there have been calls to action to move beyond these sort of outdated curriculum, the outdated frameworks that we still see informing our thinking around the nursing profession, that we have to move the needle, really advocate for a change. So how do we disrupt that? How do we go from business as usual to creating new frameworks that are inclusive, that are diverse, and that really disrupt entrenched and, in some instances, very dearly held beliefs that continue to perpetuate racist behavior? We have to have courageous conversations. And Dr. Roizen says that we all dread them, what we call these courageous conversations. But she warns us that in the instant that we need to have them, by not having them, we only worsen the situation. So we can't afford to, play the ostrich and bury our heads in the sand. We really do have to face issues of systemic racism and discrimination head on. There are two frameworks that I really like and that I have used in my own anti-racist and anti-oppressive work. The one developed by Glenn Singleton, the Courageous Conversation Framework, as well as the racial literacy framework developed by Franz Twine out of the University of California. And as you can see, each of them has different layers, because when you're dismantling these systems that have been built over centuries, really, it's going to take a very intentional, very deliberate, very sustained effort where we go through several steps, several sort of peeling back the onion that has been developed that maintains these oppressive systems. So moving away from racial literacy, we know the problem exists. What do we do with it now? We want to get to the point of racial reconciliation, where efforts like inclusive recruitment, where we have those diverse panels, where we structure our job ads in a particular way so that they don't automatically eliminate an entire group of people, where the panels that are doing the search committee panels that are reviewing and assessing applicants have done implicit bias training and are aware of their bias, and built into the actual process itself, we have developed very clear and clearly articulated metrics so that we know what we are looking for. We know what we are looking for, and that can be anybody. So we're not looking for a who, we're looking for a particular set of skills. So when we start having these courageous conversations, building out our leadership frameworks, engaging with the community in such a way that we no longer only turn our eyes to one particular community, but we expand our vision to say all can be included in the practice and the profession of nurses. So we want to move inwards, where we get to the point of actual inclusion. And not just inclusion, but inclusion and engagement, because we don't want just to recruit them. We want to retain them. We want to promote them. We want them to ascend through the organization's hierarchy to sit at the leadership table. So what do? We have to normalize these conversations. We have to normalize these courageous conversations and build into the conversations as a priority, taking action to dismantle racist and discriminatory frameworks. We have to organize our internal infrastructure. So the same policies, the same procedures, the same day-to-day activities, the same ways of thinking that excluded, we have to take those same policies, that same infrastructure, and disrupt them, rebuild them in a way that will now allow inclusion, that will allow a transformative environment where everybody feels I have a vested interest here, and my interest is no less than anybody else's. And of course, we have to operationalize, because yes, we can collect data till the cows come home, but if we don't do anything with the data, collecting ethnic or racial data or any kind of disaggregated data is important, not just in and of itself, but what do we do? How do we inform future decisions based on that data is going to be far more critical. That data will help us to understand and to appreciate that inclusion is a growth strategy. We're not just having different looking people at the table, but we're building out a growth strategy that will see better innovation, that will see better outputs, that will see better a sense of health and well-being both within the nursing profession, as well as more equitable health outcomes for the persons for whom nurses care. So how do we do that? Building these inclusive structures. The Ontario Health Equity, Inclusion and Anti-Racism Framework offers some useful advice. First of all, of course, and we've heard it for the afternoon, collecting that equity data, but moving beyond that to where we use the data to embed it in our strategic planning. Where do the gaps exist? Where do the opportunities exist? And how do we bridge the two through the real analysis of that data through an equity and inclusion lens? How do we ensure efforts to address diversity and sentiments of anti-Indigenous community are built in to our strategic frameworks and plans? We also have to invest in implementation, because the best laid plans will mean absolutely nothing if we don't actually action them. So we have to invest in implementation and allocate resources. Very often you hear about, and I like the fact that the two poll questions at the beginning asked us about our EDI ecosystems at our respective institutions, because very often you hear people, oh yes, let's get onto the EDI bandwagon, inclusion, equity, diversity, but are we really resourcing these offices in the ways that will allow the work to be meaningful, sustained, and transformative? So we really do have to invest in implementation and ensure that the resources that are needed for success and ongoing sustainability are made available. And ultimately, we want to get to the point where we think not just, again, of having different faces at the table, but we want to think of diversity, how diversity transforms into inclusion, a sense of engagement, a sense of belonging, where we actually enjoy the benefits, what we call the dividends of diversity, or returns on investment of diversity and equity, moving from diversity to simply difference, to thinking about diversity as the only road, the most effective road to excellence. I welcome any questions and comments you have. Thank you so much.
Thank you so much, Susan, for that inspiring contribution that you've made tonight. And I want to thank all the panelists. And now we have the opportunity to ask members of the panel some questions, and it will have to give us a little deeper insight, and people as well in the participants could ask. So one of my first questions to ask is, describe equity, diversity, and inclusion approaches or strategies that your employer or academic institution has implemented, and how success was measured.
So Josephine, Ingrid, or Suzanne, if any of you want to speak to that one, and we'll keep it quite brief just because we are running low on time.
Okay, I can start. I think what the example I'm giving is one that has stayed with me for a long time. It may not be with my current organization, but it's around recruitment and retention of Black nursing students. When we first embarked on that strategy at Dalhousie University many years ago, it was something that we did right from the director of the school actually being very committed to it. And we started again with evidence. This director was part of the, actually was on my supervisory committee for my PhD work examining the work life of Black nurses. And after she listened to all of that years of research, she supported the work to get Black nurses involved in mentorship program. And that really supported the work around retention and recruitment of Black nursing students. We saw over 200% increase in the enrollment of Black nursing students in the BSCN program. And we began to actually see some of those Black nursing students becoming mentors for others. And I'm hoping that that made a difference in terms of recruitment and retention of students. It's so interesting because it's nearly 20 years ago, and I had one of those initial students contact me recently that she's been reading my work and wanted me to support her to go to grad school. And she just contacted me last week again saying, you continue to inspire me because I have admission to. I gave her reference based on the years of work I've known, and she's now going on to take a leadership role. And I'm pleased to see that those initial students continue to grow and build on that. I'll stop there.
Thank you, Josephine. That's amazing. That's a great success story. Suzanne or Ingrid, did either of you want to touch on this question?
I can speak.
Oh,
Go ahead,
Suzanne.
Ingrid.
No, Suzanne, you started first. Go.
I can speak very briefly to some of the actually inclusive recruitment strategies that we have been working to build out at the Hospital for Sick Children, Sick Kids. One of the things in building those strategies I was very clear about is that we also, whenever you have a strategy, a good strategy must be accompanied by a good monitoring and evaluation plan and framework. So we do have a very clear idea of where we're seeing changes. Are we seeing changes, and are the changes we're seeing when we've done the bias training, when we've looked at our implicit biases, when we build out these templates and metrics for recruitment? Are we seeing this agency change? Are we seeing different faces? Are we seeing different perspectives? And at what point in the hierarchy are these people being recruited into the agency? Because again, people can say, oh, we're very diverse, but when you really examine the figures, the diversity is only at a certain level at the organization. So what our monitoring and evaluation framework tries to do is to show if we're seeing change, how that change is being manifest, and where the change is happening.
So can I add quickly? So to add on to what Susan is saying, what I would suggest is if the organization really wants to make change, they would start with what I call an inclusion matrix, which is a culture assessment of where they are now, where they are with their recruiting. And a lot of times you hear that we don't have any data, we don't have any metrics on these groups that are being impacted, but you can build that data. And it's very similar to what Susan's saying, going and pulling out, is there any succession in leadership? How many of these people are being hired? Performance metrics, are many of these people underperforming or indicated as underperforming? And then you start building that matrix and start addressing each of those areas and going through the systemic racism issues that created it. And then in another year, you look at that data again and see if anything you've implemented has changed. But you can create the data. For me, it's about being creatively pragmatic. So creating the data to build the story and then move it forward and choose 3 or 4 items like recruitment that you can address and start working through the diverse panels and everything else and seeing in another year how that makes a difference and the impact, looking at your performance, your succession planning, etc.
Right. And what you're all saying, what shines through is it's not a simple snap your fingers. These are strategies and these are approaches that require a lot of time and resources. And that's very clear in what you've all said. So thank you.
So the next second question, and then I'll open it up to the other participants. What best practices would you like to see your employer use to advance Black nurses retention in their institution? And I know during your discussions you did present that, but if you could just give a brief response.
I'll start this time, may I?
Yes, sure.
So,
I think one of the key things we have to be aware of is mentorship. So when we bring these people into our organizations, do we just sort of let them sink or swim? No, we have to engage with them in such a way that they understand that we are invested. And I use that word very deliberately. We are invested in their success with the organization, and we will do everything to make you feel not only that you belong here, but you can advance here, you can make a life, a career out of being here. And that mentorship doesn't necessarily have to be with someone from the organization. Use your collaborations, create synergies across agencies if someone doesn't look like you or that person in the organization. But create systems, build the infrastructure to ensure that this person succeeds.
Thank you.
I have a question, Angela.
Okay.
A very pragmatic question that we're actually tackling now at RNAO. So number one, we are looking at developing a best practice guideline as a result of all our work that we are doing with this tremendous task force. And it's a best practice guideline on anti-racism about Black nurses, specifically on the same issue that we are discussing, but broader from all the aspects that we will have in a report. So we are now looking at the job description, and we're having these conversations inside RNAO with HR. How do you post? So how do you post when I know for a fact that I'm not going to hire to that position anybody unless it's Black? You know what I mean? I know in advance that I will not. So how do you post in a way that, number one, RNAO doesn't get in trouble because, all the different aspects. Do you have job descriptions that are like that? Any of you that has experience and can send us ideas? Because right now, the way we have it, it's not basically specific enough. I have it actually here in front of me, so I can tell you what it basically says at the top, which, it's nice, but not good enough. Affirmative action, right? We had affirmative action years ago, if you remember, but that doesn't really, in my view, got what we need. So can you comment a bit from your experience, whether it's for a senior management position or whether it's for a policy position, which also we're looking, or whether it is for any position? How do you go about that?
I'll leave the HR people take the first stab.
Okay, this HR person is going to take the first stab. So
Go for it, Ingrid.
You can actually go to the Human Rights Commission and ask them for to basically allow you to hire in a discriminatory manner, specifically for Black and Indigenous.
And actually, those are, Ingrid, the two positions we're looking.
Yes.
Because
So
we have a whole program on Indigenous communities. You know how long we have been trying without putting it out there, that's what we want, and therefore we don't hire?
Yeah, so you can actually get that from Human Rights, But if you want to hire Indigenous nurses, you need to speak to the elders. You need to go where they are. You need to speak to the Indigenous community, and the elders will help you reach out to those communities, because a lot of times Indigenous people do not declare. So you may have a lot of Indigenous people sitting around you that don't want to raise their hands for that stigma. So that's what I was talking about, going to the getting that diversity in your panel and bringing the elders onto the panel. So build that community as well. And then, you know, I'm going to read a statement. If you are looking to pull people in, instead of talking about affirmative action and that space, because we don't believe that anymore, you know, it's something like we strive towards an inclusive organization where difference, uniqueness, experience, all abilities, diversity, and thought leadership build cultural awareness and respect for all, right? And you're talking about striving, you're not saying we have this now, but we're saying this is where we want to get to. And then build into your job descriptions, if you get the waiver from human rights, that we're specifically looking for this. And then you get the support of the Indigenous people and the community around there.
I appreciate that hugely, because we actually went to legal counsel for it, but you're totally right. So I didn't know that you can have a specific exclusion and they will support that. That's fantastic. Thank you.
Yeah, they will.
Thank you very
You're
much.
welcome.
And if we can connect after and you can tell us there is a specific, whether it's person, department, where when approaches, we don't need to use the time now. I will get from Brittany your email and I will put my HR with you. Thank you.
And Doris, I also wanted to add that Dion put in the chat there that Kids Help Phone just went through this process and they intentionally hired a Black VP of patient services. So
I understand. I saw it.
Yeah.
Oh,
great.
That's great. Wonderful. But the exclusion from human rights, that will be very important to not to get in trouble if we do that, which is exactly what we want. So that's fantastic. Thank you, Dion.
So we'll now open, I know we don't have much time, but we'll open the discussion to participants so they could ask. If they would like to ask a question, they could use their hand raised or could put it into the chat box, and Brittany or Imogene will screen to see who is next to ask a question. And I just hope that the panelists could give us 10 more minutes of their time.
Is that okay? Thank you all so much. So one question that's come in now, and anybody feel free to answer on the panel here. How would you address staff not on board with these changes? And Georgette, correct me if I'm interpreting it wrong, but with any strategies or changes, how do you adjust staff that aren't on board? So maybe as change management, we're talking about a bit.
So I'm going to take that one. If it's a leadership role, you need to start building diversity accountabilities into performance management. So if there's an expectation, as Doris is saying, that you want to hire very specific groups, then part of the performance, and I know it's hard in the healthcare system, but part of what leaders are accountable for should be that piece. And as you go through the organization needs to specify that accountability for diversity and inclusion is required. And if there's any other behaviors that are not supporting that will be managed or even disciplined. So.
That's excellent. If I may add, Ingrid, what we are doing internally to RNAO, because the same as we have the task force for nurses, we have actually the same committee run by Black staff at RNAO. And what we are looking at the entire HI process, from posting to performance appraisal to the whole thing. And to that, they are layering to each aspect a piece that will help tackle. Not because we have major issues, but because we want to be top deliverables in real life, to walk the talk. That's why I asked before if someone knows of an organization that is doing awesome, because we would go and talk with them.
Irma Jean, you have another question from a student?
Yes, and I think this is an important question because you spoke about the frameworks that were really embedded with discrimination and racism. And so what advice would you have for students as to how they can best advocate for new frameworks or different frameworks?
I'll take this one, yes.
Sure.
I think the students themselves have to be their own advocates. They also have to work with the allies who they identify as genuine, as critical allies, and get the curriculum changed. They also have to do their own personal work. A big part of the EDI journey is to invest in your own learning. So for them, invest in their own learning, but then take that learning, empower themselves with that learning to become advocates and agitators in the instance that they have to be, really agitate for that change to happen, work alongside with allies and get the curriculum changed.
Okay.
Thank you. And Keisha, I see that you have your hand up. Are you able to unmute or a video if you want to ask your question?
Yes, can you hear me?
Yep.
Yeah, okay, perfect. Well, first up, I just want to say thank you to all the panelists. This was phenomenal, so filling. I just wanted to maybe make a comment, I guess, more so than a question, but just listening to Dr. Atoa speak about the Dalhousie nursing program, and as a current Dalhousie student, one of the things that I'm observing now is just the fact that systems really like to revert back to the origins and back to oppression. So this phenomenal program that Dr. Atoa started 20 years ago has been dismantled. And now we are fighting to essentially reinstate that program. So what we're seeing is there's a small group of us in the School of Nursing who are essentially advocating and trying to bring back elements of what Dr. Atoa had established, because with her program, we were, as she mentioned, seeing 200% increases of Black student enrollment, which led to, at least 13 to 15 Black students graduating the nursing program, which now the numbers are down to about 1 or 2 each year graduating. And we had designated seats, those have been removed. There was an equity officer, that person has been removed. So the elements have been removed and the system has reverted back to oppression. So that's just another, I guess, aspect to be mindful of, that the system wants to go back, the system wants to oppress.
Can
I make up? Okay. Go ahead, Doris.
That's why I ask you, Josephine, also about your experience with grants and research, because I wanted to say to Keisha, also the same issue exists on gender, as we know, right? It's much, right? So here it's layered, it's gender plus then races. So tell us because you're very successful, right, at grants, or I think at least you are. Tell us if you have ever experienced in the process of writing grants that you, or on responses, how do you tackle that? Because that's critical also for us from the scholarship perspective.
Yes, absolutely. First, I want to say, Kaisha, thanks for sharing that, because that continues to be a very troubling aspect of these changes, even when you try to embed it within the institutional structure. So directors and other people have their role. Once that particular director leaves, then the program falls. I'm seeing that even in my current university, where I replicated the same program with indigenous students, seats reserved and all that at the University of Ottawa, and it just took a change in director to start seeing it pull apart, and so it becomes very hard to continue to put in hours of work into it. But well, the work is big. That's why I say we continue to see the issues we saw 20 years ago, even in studies we're doing right now, we're seeing it. Yes, Doris, it's taking. Yes, there's definitely discrimination and racism in our funding organizations. when you look at some of the funding, research funding organizations in the US, they actually tell you to put in race, like how are researchers accounting for race as a variable in how we measure many disease conditions and the social determinants of health. And it's not there. But even as a visible minority researcher, when you see questions asked in your grant, my team have gone in to ask questions about who reviewed this grant that made statements that are not even relevant to our applications. We've had things like that. Or they just see you talking about race. I've had somebody, another colleague, approach somebody to remove the word racism from the description of my bio in a grant submission because they're afraid we may not get it if we describe me as doing research on racism. So yes, and you fail and you pick it up and fail. So it took me years, especially when I left Nova Scotia and moved to Ontario. It took 5 years to resettle and again start getting grants. And yes, so you would face that. And at some point, I stopped researching racism and moved to HIV until the success started coming. Then I started pulling in race again. You almost have to if you want to succeed in getting money to run your grants. And so that affects even younger researchers coming who, because of the internalized racism, you may see them even run away from being mentored by a Black leader because they'll rather be associated with a white leader so that they're seen as doing something different. And that's a whole package in itself that requires a study in itself or requires addressing because that further marginalized, you fought so hard to get up in leadership, but even the younger ones coming after you discriminate against you. So it's complex. Yeah, because they don't want to deal with what you're dealing with. And so maybe it's easier to not be associated with the person who talks about racism and go the other way. But then how do we really address it? It's very complex.
I think for the sake, just to take note, for the sake of the report, Brittany and Angela, I do think we need to do a bit of more homework on the issue of scholarship and research, because I feel quite comfortable, maybe because I know more that area, on the issue of human resources, on the issue of hiring, on the issue. I think we will tackle those pieces and we will create and push processes, including with the CNO, that are very, I think will be solid. I think we need to tackle the same with CIHI, CIHR, etc. So we may come back to you, Josephine, and to others that we have discussed from scholarly perspective to how do we go about that? How do we, because we have now some good people. If you know Jennifer Zellmer from the two organizations that merged together, CPSI and the other one, there are people that are in positions now that are on the same path, on the same agenda, that we need to take advantage and try to push whatever we can. You know, it's what you said before and Keisha said. Then people leave, and you're right, people revert to the past, but at least if we can have 10 years of something will stay, some seats will stay, right?
I'd just like to add, as one of those people who went through academia at the University of Toronto, when I started doing my PhD on cultural competence, we all had to present what our research subject was as second years PhD students. And the faculty was thinking culture was race. And I had to say culture is not color, and had to define what cultural competence was. But I know one of the professors there who was doing studies on race, she had a difficult time getting her tenure.
No kidding, Becky.
Becky.
Peggy, no kidding. I was, darling, I left the University of Toronto for a reason after a year, but I was witness to what they did to Becky Hagee there. In any case, let's not go to the.
I don't want to go there, but as coming to the funding, I had a strong proposal sent to CIHR with good researchers on it. But because I was looking at culture with specific groups at the time.
Yeah.
I did not get a grant.
Yeah.
Yeah. And
Yeah.
it's done in a polite way. They will state reasons. One time they will tell you something unrelated. It's, oh, translation. You did not put in French translation. The next time you put in French translation, oh, it's too expensive. You have a big budget for translation. Rejection. There's always some reason not really related to the real issue.
We absolutely will put, well, you will help us to put, all of you, on how to tackle this, because you know, we need scholars and we need researchers, and we need scholars and researchers that actually study racism and discrimination if we are going to tackle the path to it.
And Ingrid, if you can unmute yourself there, if you wanted to ask a question or make a comment, it'll be our last one.
Yeah, I just wanted to say that I've been a nurse for 36 years. And I would say 25 of those 36 years was spent on some kind of diversity committee or the other. Now it's called the Legacy Committee. But we did make some inroads this year, thank God, because there is now anti-Black racism policy in place. And part of that policy has, it's a tiered policy where there's responsibility at every tier. So there's responsibility of managers, then the directors and the CEO. And research is part of that. Collecting data is part of that. Because there's a recognition that there is certainly a disparity that affects patient care. There's no doubt about that. So it's in the best interest of the hospitals to find out the cause and correct it. And this is a first step. And I hope that that's the groundwork that most hospitals should have. And it's up to committees like the Black Legacy or the Black Diversity Committees, whatever they wish to call them. It should be part of their mandate to make sure that those policies are kept alive and enforced.
Well, I'd like to thank the panelists and all of our participants for your engagement and your contribution to this evening discussion. And I'd like to call on our CEO. She was going to mention some call to action before we close the session for the day.
Thank you so much. I guess the first call to action, Angela, is for people to look at their own careers, and if you cannot find those positions, to connect with Dolores Serran. I put her email there because there are several positions. We are expanding the best practice guidelines program, so there are positions in BPG implementation science, as well as guideline development. And we are also looking at 2 policies in policy. So if you are interested, there's a note at this stage, senior positions, but you know, they all lead to senior positions at some point. People are staying at RNAO, so here you go. I see Daniel from membership is there. Daniel, how many years are you with us? I thought I saw Daniel before. Many, many years, I think 15 or something. But this is a key area that we are tackling at RNAO. So by all means, please. Second, the action alert. Please, 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 please. Today is the day to push with that action alert, and tomorrow I'll pass it to everybody. What we are asking is very simple. We are asking to close all non-essential workplaces, because that's where you have people with precarious employment that are working on minimum wage, that do not have benefits, that do not have sick time. And by the way, just so you know, so do nurses that work for agencies, and we have many, and many of them are Black nurses, you need to know, that work for agencies for the simple reason that they have more flexibility to take care of their lives, and they make a little bit more money that they can help their own families. So many work for agencies, not because they cannot do a better job, it's because they do that by choice, but they don't have sick time. And that is terrible, right? So I know of colleagues that have been in quarantine 2 weeks without the pay. And casual nurses don't get benefits. So please, this affects everybody. Of course, more even so people that are on minimum wage. And then these workers go back home and they live in, I will call it what it is, because we have decided in a group that is not just multi-generational, it's crowded homes. Not because they want to live in crowded homes, but because with minimum wage, guys, you cannot afford a bigger home because they could live with multi-generations in big homes, right? That's not the case. And then these are the people we are seeing in ICUs. These are the people we are seeing in ICUs. So we need to take action on that. That's number one. And of course, number two, think of our colleagues, reach out please to our colleagues, ask them how they're doing, especially those in the front lines. Ask them how they're doing, provide them, even to connect with them. On Friday, I connected with the chief nurse, Scarborough Hospital, an amazing woman. You know, it touched my heart that she was touched that I called her. I was just wanting to thank her to the moon for what they were going through. Reach out. It means the world to people if you reach out. We are helping them through our RNAO. We reopened via nurse to have people go to ICUs. About 300 people already volunteered, put their names, and we have connected. Daniel has connected them all. Thanks, Daniel, for working with us on that. And be careful, guys. Be careful. I'm not saying don't be outside. Just be careful how you are outside, because this is a nasty virus, and there is a new variant coming also from India now that is even worse than the Brazilian one. So just be careful with yourself, your families, your friends. We do have on April 20, the Connecting Culture, Land and Wellness to Indigenous Youth webinar. These webinars are out of this world. We had one with, they don't like to be called elders, by the way, knowledge keepers. Some of them are not older people. And it was fantastic. We had a debriefing the other day with them and with Grace. And just so you know, our panelists mentioned connect with knowledge keepers or elders. Yes, of course we do. We also connect with CINA, the Canadian Indigenous Association, so that, and we have now an interest group, by the way, of Indigenous nurses that they requested to have an interest group. So we are working all together. Institute of Nurse Practitioner, April 21st, this week. And if you are a nurse practitioner, I strongly recommend that you attend, because we will have Commissioner Morocco presenting and a fabulous response panel. And also that session will be open for all RNAO members, the session on Commissioner Morocco, and maybe you can put the agenda, Brittany, so people can see when is that session that is open to everybody. I said before, an RNAO, we have said it many times, first and second wave, they were about ageism. Third wave is racism. Simple, as simple it can be. It was all along, as I think several of you said, racism in terms of the people that took care of people in nursing homes. Now it's racism in terms of the patients that are in ICUs. COVID-19 webinar, May 10, 2 to 4 p.m., always very well attended. You are welcome to attend. And if any of you do not receive the blog I sent every weekend, we had a fantastic submission by Amanda Oakley that wrote about how she's working actually with Black communities and others actually, and in pop-up clinics. And if you want to volunteer, if you want to help, it's in the last blog. It's a fantastic work that she and her community are doing. If you have other areas that you would like to contribute, you would like to share, the 3 presentations you guys did today were fantastic. if any of you wants to develop a 500 word, a 300 word, a 700 word, and put it in the blog, please know that it reaches now 300,000 people in Ontario, Canada, and abroad. So it will be well put to use in practical terms by the people that read it. So if you are interested, please send me a brief note. I will put Anne-Marie, can you put my email there? Both if you want the blog or if you want to send a piece, by all means. We always not accommodate, we welcome people that actually want to contribute. So I am going to put my email now because I think probably I remember it easier than Anne-Marie.
Thank you, Doris. And to close off, our last promotion of an upcoming webinar and event is next month's in this series on May 17th at the same time. We hope you can join us. And we actually have her here tonight, Nadia Prendergast. Her and her daughter will be focusing on the topic of an intergenerational conversation addressing anti-Black racism. So that's Nadia Prendergast and Leanne Prendergast. And we hope you can join us, and you can register at the same event link, but keep an eye on your emails and inboxes for more information about that. And I'll hand it over to Angela to say some closing remarks. And
I just want to thank you sincerely from the bottom of my heart for the panelists, for the participants, and all our supportive staff from RNAO and our CEO for making this such a successful event. We have learned a lot. I hope we take it and put it into practice so we could improve things in this province and also internationally, because it has great import for international audiences as well. So thank you so much. And I look forward to connecting with you. And Josephine, I will send you an email. Have a pleasant evening, everyone, and thanks again.
Thank you all.
Thank
I have to
you.
say,
Bye,
it
all.
was a perfect symphony tonight with having Ingrid, Suzanne, and Josephine. We had some HR, some project management with EDI. We had nursing research and academic. It was perfect. So thank you all so much. We really appreciate it.
Thank you very much, everybody. Take care.
Have a good
Bye-bye.
evening. Bye.
Good night.
Bye.